My talk today is entitled, as you can see, Being True to Nature and Respectful of How Far We've Come. Now, Chris and I decided to work together on this, which is unusual in these kinds of debates. But Chris and I have worked together for years, and he's already seen my slides, so I'm sort of setting up what we're going to be talking about, as well as my own opinion. Personality disorders first entered our nomenclature with operationalized criteria and cutoff scores for 11 disorders in 1980 in DSM-3. Before that, DSM-2 had paragraphs. They were quite good, but you couldn't really study very much with them. Since that time, disorders have been added and dropped, and criteria sets have been revised in small and major ways. Now, in the ensuing 38 years, some in our field, many in our field, have repeatedly noted what are seen as serious problems with these criteria sets or diagnostic categories. For example, too high rates of comorbidity due to partially overlapping criteria. While criteria sets can be revised to lessen areas of overlap that really don't exist. For example, histrionic personality disorder the criteria were changed enough so it stopped overlapping so much with BPD. Cutoff scores that may not have been the result of research findings but consensus clinical judgment. And I'll tell you later where we have done cutoffs based on evidence. There's not been much research in this area that's been conducted for the alternative model either. And heterogeneity within a diagnostic category is extremely common in medicine. For example, we have the cancers, we don't have cancer. And in psychiatry, the schizophrenias, we don't have schizophrenia. Now, the dimensional alternative model, which I assume many of you, or most of you, all of you, are familiar with, as described in DSM-5, there are two main components of a diagnosis: personality functioning and personality traits. DSM-4's significant distress or impairment in social or occupational functioning has been replaced by an extremely complicated list of 4 self and interpersonal domains and 12 subdomains which differ by diagnosis, and vocational functioning is not mentioned at all. In addition, 25 personality traits or facets under 5 broad domains are assessed: negative affectivity, detachment, and Leanne has already mentioned these, disinhibition, antagonism, and psychoticism, which lead to 6 diagnoses. Now, I have a series of concerns which I'm going to outline for you. And someone just threw something around the room, but I'll address that issue later. Traditionally, diagnostic criteria are based on the problems and concerns better known as symptoms raised by patients or would-be patients coming for their first consultation. This patient-centered approach is used in most medical specialties, even those that now have an objective test or procedure that confirms clinical impressions. The alternative model, in contrast, is more theory-based than patient-based. In the categorical model, I believe we go from patient telling symptoms to clinicians who come up with a diagnosis, and I'm particularly fond of this idea because through marriage, I'm related to Sir William Gull, who was Queen Victoria's personal physician and was the first to describe anorexia nervosa. And what he wrote about in his time, basically is what you see in every DSM. And out comes a diagnosis. I worry that in the alternative model, we have a theory that'll be filtered through clinicians, and the patient will be at the end of the line, not at the beginning of our line of assessment and treatment. My second concern is that I feel that the alternative model is in some ways backward looking, as developing operationalized criteria was the focus of research in the PD field more than 40 years ago. And many of you are too young to know that, but the main journals were just full of articles about how to develop and data sets about this and that criteria set. For example, BPD has moved over these years from a wastebasket term for patients who baffled and annoyed clinicians to a diagnosis that has been validated according to the criteria of Robbins and Gouset in 1970, who were the precursors of our DSM system. My third concern is that the alternative model could well lead to more diagnoses of chronic PDs rather than the work of the CLIPS and MSAD studies and the work of Lee Robbins on antisocial personality disorder and actually on histrionic personality disorder, that high rates of remissions are to be expected as personality disorders are forms of immaturity and are not immutable clusters of symptoms or personality traits. I'm also worried that this model could take away the motivation, if we see all these disorders as chronic, to develop ever more effective treatments or any effective treatments, and the hope that patients and families now have. Before, for example, borderline personality disorder was so stigmatized that clinicians never told patients they had it. Now when patients and their families know they can expect a symptomatic remission and often strong improvement in psychosocial functioning, patients and their families are relieved, and patients in particular have gone from feeling that they're alone to knowing that they have an illness and that there's hope for them. And I would not want to see any of this hope pushed aside. My fourth concern is that we could destabilize established clinical and research programs, many of which have been going on for many years. And this might lead to less funding for treatment and research programs aimed at alleviating suffering and instead focus on studies of symptoms of nosology, such as high top, or very focused aspects of psychopathology that, in my opinion, will not have much impact on clinical understanding or treatment. My fifth concern is that we could accidentally decouple PDs from the rest of psychiatry and medicine more broadly, as these dimensions at this point have no clinical meaning. They're not attached to prognosis or treatment approach. For example, with various cancers, they have various numbers attached to them for stage and grade, and that absolutely guides clinicians as to what this person's prognosis is likely to be, although they can't tell for sure, and also what treatment protocol they should follow. We don't have that in psychiatry anywhere, and we particularly, I think, don't have it in the PDs. My sixth concern is that we could also decouple PDs from the rest of psychiatry and medicine by pathologizing aspects of functioning that are not ideal but are not typically thought of as an area to treat, particularly in medicine but also in psychiatry. For example, someone has an impaired capacity to reflect on inner experiences. They're not introspective, they're not psychologically minded. I doubt that many endocrinologists or rheumatologists are really worried about this. They can see it in their patients, but they can also work around it. Rather, symptoms that cause pain and distress are targeted for treatment in psychiatry and medicine, and symptom alleviation. For example, someone so anxious that they cannot leave the house. As are symptoms that interfere with psychosocial functioning. For example, frequent migraines interfere with working and getting together with friends. My seventh concern is that DSM-PD diagnoses are not used that frequently due to belief that they're harder to make than those for symptomatic disorders, which I don't actually think is true. And there are also concerns about stigma, and again, that applies primarily to borderline, narcissistic, and antisocial personality disorder. However, the alternative model will be used even less in clinical settings. It is too time-consuming. Chris told me that he interviewed someone as a volunteer, and it took him 2 hours to do so, which is a lot of time. It's also simply not the way clinicians function. That clinicians don't use self-reports or interviews. What they use is they get a sense in the first meeting or two what the diagnosis the person probably has, while they're listening to the person describe their life narrative in a way that makes sense to them, without a whole lot of interruptions. It's also too complicated, psychosocial domains and subdomains and traits and facets, and also the language is abstract and unfamiliar. I'm sure to many of you it's not that abstract and unfamiliar if you work in a psychology lab, but for those of us who work in hospitals, people don't suffer from negative affectivity. They're in emotional pain. Now let's talk a little bit about these as we look at BPD. The history of the borderline diagnosis. Alfred Stern first described these patients in 1938. He saw them as a group that was neither neurotic nor psychotic, but they occupied a mid-position. And it first entered, as I mentioned, our nomenclature in 1980 with the DSM-3, and we've had DSM-3R, DSM-4 and 5 revisions, have not changed the criteria much, with the exception of an addition of a cognitive criteria in DSM-4 around suspiciousness and or dissociation. Now, here are the things I see are problematic with the alternative model for BPD. It leaves out cognitive symptoms common among borderline patients that are included in DSM-4, as I just mentioned, suspiciousness and depersonalization, derealization. Instead, these symptoms are put in schizotypal personality disorder. They may belong in both, but there's a tremendous amount of research, high-level research, about how these symptoms are common in borderline patients, and to leave them out is to leave out an entire sector of psychopathology, and instead list them under psychoticism, although they're not psychotic symptoms. Serious identity disturbance is now part of functional impairment rather than a trait or symptoms. And suicide attempts are listed under depressivity, which implies that the only reason you would ever attempt suicide if you're borderline is that you're depressed, and there are many other reasons for attempting suicide. While self-mutilation is listed under impulsivity, while most of us know that many people engage in self-harm in a very compulsive, ritualistic manner. Also, risk-taking, for example, drawn to thrilling activities, is not that common among borderline patients in my experience, while engaging in risky behavior, for example, sex with someone you just met, as a way to manage dysphoric affects and troubled cognitions is common. I want to tell you a little bit about our work. We've used the revised diagnostic interview for borderlines over the past 30 years. In the 1970s, John Gunderson developed the DIB, and when I came along, when I was actually a pre-doc, I said, well, I'd like to revise this because I don't think the issues anymore are schizophrenia and depression, it's other personality disorders. And he was amazed, but he said, well, okay, go for it. This is a dimensional and a categorical interview. It measures dysphoric affects, disturbed cognitions, impulsive behaviors, and troubled relationships, and they're all required for a BPD diagnosis. It's a more, something people want, homogeneous diagnosis, although people are not identical. And it has dimensional scoring of the 22 symptoms studied, the 4 sector scores assessed, affects, cognitions, behaviors, and relationships, as well as an overall score of the DIB-R, and we use both scaled and unscaled scores. And our cutoff was determined by having a balance between sensitivity and specificity against the gold standard clinical diagnoses by experts. Now, I'm suggesting perhaps another dimensional approach, which is, and I just put this together quickly, it certainly could be better. 0, you have no impairment in social or vocational functioning. 1, you have mild impairment in social and vocational functioning. For example, you have some friends, but you do not see them that frequently. You work part-time when full-time jobs are available. 2, moderate impairment in social or vocational functioning. For example, you rarely see friends. You don't have a steady job. You're often late or absent without a good reason. And serious impairment in social or vocational functioning. For example, you have no friends or romantic partner. Your relationships are chaotic with those you want to be close to, you feel you are close to, and you don't go to work or school, and you're on disability. This would allow us to pair the impairment in a dimensional way with not only categorical diagnoses, but diagnoses that themselves can be dimensionalized by severity. And both of these things can be used to assess whether they're good predictors of long-term psychosocial impairment and or symptomatic remission. This dimensional assessment is much easier to use, and therefore I think it's more likely to be used, or something like it. And again, categorical diagnoses, which can be dimensionalized by severity, can then be studied for prognostic significance and treatment selection, which really is the point of a diagnosis. A diagnosis is the way to tell patients about what they're suffering from and their families. And it's a way to communicate with other professionals. And it's also, we desperately need to be able to think about what someone's prognosis is and the best treatment selection at baseline, something we just don't do in psychiatry, and something we really don't do in personality disorders, where we seem to go all in, all out, no matter what, sort of ignoring Joel Paris's step model of care. No other concerns with the alternative model. Disorders with a long clinical history have been dropped: paranoid and schizoid personality disorder. One with a robust evidence base was dropped: histrionic PD. Others that could be merged with symptomatic disorders were retained: avoidant PD, which could be merged with the anxiety disorders, and schizotypal PD, which could be merged with psychotic disorders. And antisocial personality disorder was changed from a disorder of incompetence, which is what Lee Robbins actually described, to psychopathy. And having worked in a forensic setting when I was a trainee, I can say that her description of both the adult criteria and the child criteria really described every single person, even though this was a high security mental health facility that was run by our prison system. Psychopathy was they were all guys who were in there, really were psychopaths, but they were actually pretty rare, although unfortunately, because I was a trainee, those were the patients I was assigned to. So in conclusion, before we have Chris come up here, when we're replacing one model with another, and that's what we're really talking about, it should be markedly easier to use, not more difficult. It should not upend existing clinical and research programs, and it will, if it were made our official system. And it should carry substantially more prognostic information, which I don't think it will, and that it would guide treatment, or that the prognostic information would guide treatment decisions. And let me just say, I know that these discussions have often been very emotionally fraught in the past, with people making unfortunate ad hominem comments. I have the utmost respect for those who've worked in this area. It's not my area, but I know how hard people have worked. I know how much all of this is meant to help patients. I just don't think it blends well with what clinicians do. And clinicians, in my experience, only know what was in the DSM when they were trainees. Whatever comes behind, they never read, because they don't have any time. And they also feel the disorders haven't changed that much, and they're looking at something in nature. So, and I also, by the way, have to say the criteria and the questions for narcissistic personality disorder are so much better than anything the previous DSMs or existing DSM official diagnoses have, and I feel that both you were all very smart to do that, but you also had, well, more recently, proof that those criteria really describe people. So, with great affection and respect, my collaborator, Chris Hopwood.